Good evening and welcome to St. George's House in Conversation. I'm delighted that so many of you are able to be with us tonight, although I have to say I'm not surprised given the topic to hand. And thank you also to those of you who have sent in some questions in advance. And I should say that if you feel moved to ask a question in the course of our conversation, please do use the chat option. I'm delighted to welcome our guest this evening, Sir David Haslam. Sir David is a former president of the British Medical Association, a former president of the Royal College of General Practitioners, and a former chair of NICE. He is also the author of this book, Side Effects: How Our Healthcare Lost Its Way and How We Fix It, which I have to say is a hugely interesting and stimulating and practical forward-looking guide to the health sector and where it may head in future. We'll come, of course, to the book, David, very shortly, but I just wanted to ask you, given your 35 years service as a GP in Cambridgeshire and your involvement with these various organizations, what have you seen as the major advances in the health sector?
Well, first of all, it's an absolute honor and delight to be joining you this evening. And I have to say, when I looked at your website and saw the list of the previous contributors to this slot, I felt deeply intimidated, but there we go. What's the biggest change over my professional career? I guess it's probably the fact that my father died much younger than I am now of conditions that are now preventable and treatable. My brother died, in his late 30s of conditions that are now a condition that's now treatable. There's been the most extraordinary advance in healthcare. And so in terms of the main outcome, the focus on mental health, the focus on so many other aspects of health have been an enormous step forward. But of course, every step forward brings problems as well. And that's the challenge.
Yes, and of course, the NHS is constantly in the news, usually around crisis, usually around problems, whether it be waiting for ambulances, whether it be the queues for cancer treatment, all of that. There seems to be this sense that it's never out of crisis. And I just wonder, in some ways, the original concept shortly after World War II was a very honourable, very noble, and perhaps practical and practicable option at that time. But do you think it has run its course in its current format?
The basic principle in which we provide care for people irrespective of their ability to pay, I think is absolutely fundamental to our civilized society. I think it's something I'm enormously proud of, to work in the health service. I've always had great pleasure over the years when I've occasionally treated American patients and not given them a bill. This sense of moral superiority is really quite something. But it's a serious point that the very fact that we don't ask. I mean, I wrote in my book about the fact that 3-4 years ago, I myself had cancer, and I genuinely, as I sat up off the radiotherapy table, I remember thinking, isn't it extraordinary to live in a country where my fellow citizens have just paid for that treatment I've just had, and I've paid for their treatment as well. We've shared the risk, we've shared the benefits. I think it's an extraordinary, noble model, and I do think it has a fantastic future. I certainly have no wish to do away with the basic premise of the health service. But I do begin to question all sorts of other issues, not least a lack of clarity as to what it is we're really trying to achieve. And that might sound a slightly nonsensical statement, because the last time you went to a doctor, last time I went to a doctor, I know exactly what I wanted for me. But when you're looking at the population as a whole, what is it that we're trying to do? What is the intended outcome? Are we trying to reduce health inequalities? Are we trying to improve overall outcomes for the population? Because if it is, we go about it in the wrong way. All the global evidence, for instance, is that if you want to achieve those two areas, you invest much more in primary care than secondary care. That isn't to knock secondary care, it's just to look at where the evidence of where you get your bangs from your bucks. But in fact, the investment goes in the opposite direction. And your comment, Gary, about the sense of crisis always being there, I've had this sense for years, and I've discussed this with politicians, that I think crisis stories tends to drive policy. I don't think there's been a single election I can remember when there hasn't been a story that becomes a headline. Do you remember the story of Jennifer's ear some years ago, a child who was waiting for an ear operation, for instance? That becomes a major story. And so politicians very understandably focus on individual noises and crises, whilst failing to notice the incredible benefits that you can get from prevention, from public health, from investment, from looking at the whole system in a different way.
Which, of course, doesn't make news and doesn't make headlines when you look at it in that way. And I just want to stick with this issue for a second, because earlier this week we had that story from Scotland that health chiefs, a story strongly denied, that health chiefs were talking about the possibility of charging people who could afford to pay for the service. Now, do you think that that's a route we might in the end go down, or indeed have to go down?
No, I don't at all. I was inundated with calls from radio stations after that came out from Scotland. What I hope was happening there is something that all civil servants do, which is draw up lists of all the possible things we might do to address the current challenge. And then I hope they fairly rapidly throw it in the waste paper basket, because it isn't a solution. And indeed, I've been enormously privileged in my career to be able to travel the world and speak to health ministers in countries around the world, and they all face very similar problems. So the thought that shifting to a health insurance model, for instance, or a private practice model solves these dilemmas about many of the long-term dilemmas, I think is a nonsense. So I think our model fundamentally is savable as long as we're a bit clearer about what it is we're trying to achieve.
Okay, and just to return to what you said about primary care and health inequality, I mean, all the evidence, as you rightly say, is very clear that if you invest early in prevention, in equality, then the knock-on effect is much better. But if all the evidence suggests this, why is this not happening?
Well, I had a wonderful example of this a few years ago, in which I was talking to a cabinet minister, in fact, who was telling me this story about a friend of his who'd had a heart attack and had been admitted to hospital and had had the most wonderful treatment within 24 hours. He's had stents fitted, he was on the right drugs. Within 48 hours, he was in the gym. I mean, it's miraculous. And this MP was incredibly impressed. And I said, yeah, I'm incredibly impressed. It is wonderful. But tell me, what would you prefer, having all that treatment done really effectively and quickly, or not needing it in the first place? And he looked at me as if I was completely mad, as if this was things you can't compare. But I pointed out that investment in primary care would, and in public health and so on, address things like blood pressure and cholesterol and smoking and obesity and all the risk factors that fit there around that person potentially having a heart attack. But the problem is, of course, prevention doesn't have a story. So even the person who doesn't have a heart attack doesn't know they didn't have a heart attack. My GP's very good care for me might have prevented me having a whole bunch of things. I don't know. So there's no story. There's nothing to get excited about.
Yeah,
so from a political perspective, I can absolutely understand why the dramatic stories always get the headlines.
Yes, I mean, as you say in your book very effectively, are we focusing activity on the dramatic rather than the effective? And there is no story for the politicians. But I wonder also, given the parliamentary cycle, the 5-year cycle, something as huge as the NHS, it seems to me, needs planning far further ahead than that. 5 years is much too short a time to really put a strategy in place. So is there a way that we can move away from the 5-year plan to the 20-year plan or the 25-year plan and make it binding?
Well, I couldn't agree with you more that this short-term budgets are a nightmare when it comes to the health service. Sadly, I'm not sure what the solution is to that aspect. Andrew Lansley's much criticised reforms of the health service back whenever it was 2012, setting up what was first known as the NHS Commissioning Board and then now known as NHS England. The model behind that was to try and depoliticize, to try and treat the health service like the BBC, or board of governors who are responsible for it, but it's taken out of the politics. Well, we know both with the NHS and the BBC, that's a long way from happening. And of course, there's no way that something that consumes such a large proportion of our GDP can be depoliticized. There's no way we're going to have Secretary of State for Health when there's a major crisis to say, sorry, Gov, nothing to do with me. I mean, that just isn't going to happen. So that's not an answer to your question in terms of a solution, but it's a recognition of why it's still so political.
Yes, and given the various positions you've held throughout your career, has political leadership helped or hindered during that time?
What a really good question, and an incredibly difficult one to generalize on. I think the thing I always found frustrating is the turnover of ministers and secretaries of state. And from my perspective, you took a while to educate them in some of the things I'm passionate about, and then they promptly moved on to another role. I mean, Jeremy Hunt did 5 years as Secretary of State for Health and Social Care, which was something of a record, and he absolutely got it. And in his autumn statement, talked about many of the issues that he'd picked up in that. So I think politicians, they all want to make a huge difference, but as I said, I don't think they've really got a clear vision of what to do, what it is that they're trying to achieve. Are we trying to maximize, as I say, are we trying to maximize for the majority or for the exciting few? And you only have to take the examples of the incredibly dramatic, very, very expensive treatments that get the headlines and are wonderful. And, I've been, as I've said, I've been treated for cancer. I'm really grateful for that. But we do that at the same time as leaving tens, if not hundreds of thousands of people having a dreadful old age, a lonely, dreadful old age. This gets us in the whole social and healthcare nonsense. But and was that a deliberate decision, or is it just that we followed where the headlines were? So I'd just like a bit more talk about what the intention is across the population. Right. And the other, of course, the other challenge is that the solution is always seen as, well, the NHS needs more money. And yes, in the short term, I do believe we need more money. If you look at our proportion of GDP spent on health compared to Germany, France, and so on, it's significantly lower, and our number of doctors per head of population, our number of scanners and so on, much lower. But money isn't the only answer. And you only have to look at America, which spends double the proportion of GDP that we do on health and has overall worse outcomes. Or look at Cuba, which spends a tiny amount on health and has very good outcomes. Yeah, go on.
Sorry, just looking at that international dimension, and you have seen health systems across the world. Are there lessons that the NHS can learn from other systems? As it often seems to me that we're very bad at learning from other countries.
Well, no, I'd agree with that, absolutely. I remember a few years ago, Lord Nigel Crisp wrote a wonderful book called The World Turned Upside Down, in which his work in international development and international healthcare systems looked at what was happening, for instance, in rural India or parts of Africa, and said the way they approach dealing with many healthcare problems there, we could certainly take on board in this country. So no, I agree, we're not terribly good. We're very good at looking at bits of the states and saying we'll have that bit, but globally, I think And I found healthcare systems around the world are really, really interested in what we do. There's an extraordinary passion for understanding how the NHS works and tries to address things.
Okay, and just a question that has come in from one of our viewers. What is your view of the role that integrated care systems can play in the prevention agenda and population health management?
Well, it's a great opportunity, and it's the concept of bringing together many more aspects of health and social care and the local authorities and so on, I think is a wonderful aspiration. It's really quite difficult to get to my age without developing a level of cynicism, and most of the PowerPoint presentations I've seen on integrated care systems and boards have exactly the same expected outcomes as I've looked at every other redisorganization of the health service that's gone on over the last 20 or 30 years. Now, I hope this time will make a difference, because it is critical, absolutely critical to deal with this health and social care gap, to bring systems working together. But it takes more than a board. It takes culture, getting trust, getting medicine and healthcare and politics are incredibly tribal, and the different bits tend not to trust each other. And you have to build that trust to get the results that will make a difference.
Yeah, and that trust often depends on the expertise to hand. And you're very interesting in the book about that quote from Michael Gove about how the country's tired of experts. And you asked the question of how the public regain trust in those with genuine independent expertise might be one of the most important issues of our time. I wonder if you'd say a little bit more about that.
Yeah, it is extraordinarily important. This need to be able to trust people. And I'm not talking about this in a paternalistic, doctor knows best way. I think it's really, really important that patients, all clinicians, work much more together. There's a lovely cliche going around at the moment about finding out what matters to the patient as well as what's the matter with the patient. Working with people, recognizing that, I think I say in the book, if you're a patient with type 1 diabetes, you probably spend a few hours a year with a clinician and hundreds and hundreds of hours by yourself managing the condition. So your expertise and knowledge there, it's working. So the more we have mutual respect for each other's understanding of conditions, the more we can build on this. And that also takes doctors and other clinicians not jumping to assumptions about what patients want. I quote fascinating research that shows that doctors tend to choose much less treatment for themselves than they give to their patients. When it comes to cancer or many other treatments, they opt for but they assume that that's what their patients want, or they worry that they'll be criticized if they don't do everything. So we end up with a thing I write about a lot, which is over-treatment, which is quite significant.
Right, and interestingly there, because a question I've had from one of our listeners also is, has the attitude of patients towards the NHS changed during your career? Do patients now demand more and offer less?
Well, I'm not going to sort of sum up 56 or 60 million people or however many we are. I think there has been a shift. I practiced in a rural area, and certainly at the beginning of my career, many old people put up with a huge amount of conditions that nowadays they wouldn't put up with. And I'm not criticizing either of those, it's just the way it was. And there's been a significant shift there. Expectations have gone up without a doubt. But what really fascinates me, one of the things that drove me to write the book was looking at, I had to give a lecture a few years ago based around one of these eponymous lectures based on the life of Sir James Mackenzie, who was a doctor practicing in the later 1800s. And looking at what he dealt with in his morning surgery, pretty well everything that presented to him we've now wiped out, but we're busier than ever. And that made me extrapolate forwards 100 years and say, so in 100 years, will we wiped out everything that's here today? Will all the waiting rooms be empty? No one consulting a doctor? I don't believe it for a moment, which then drove me to this question of so what is the end game in all this? And so there has been that very, very real change. And bizarrely, over the course of my professional lifetime, the number of times the average patient consulted a GP in a year doubled. So it was 4 per citizen per year. It's now 8 per citizen. What's that about? If the population is healthier than they've ever been, living longer than they've ever been, but they're consulting twice as often, what's that about? Which direction is the linkage there?
Right. And just thinking about, you mentioned earlier, end of life care. Do you think we've got that right in this country? And I asked that question because there seems to be a real emphasis on keeping people alive, even if that means they're in discomfort, their quality of life is very poor. Is that something we really need to address as a society?
I think we do, and I absolutely want to stress that this has got nothing to do with saving money. It's not saying we shouldn't treat people because it costs too much. It's to do with quality of life, and I find it deeply depressing to see, for instance, a very elderly person with severe dementia who develops pneumonia and is rushed into hospital, and then perhaps has CPR and broken ribs and so on. And none of that is kind, and it just feels to me it's a wrong direction to have taken. And there's again fascinating research that good palliative care can give a better prognosis in some cancers than aggressive chemo or other therapies. So it's that focusing on quality of life is just so important. And I think whether it's fear of litigation or terror of doing the wrong thing that leads to a lot of overtreatment at a phase that's going to hit us all.
Right, but with end-of-life care, does that require a cultural shift?
I think yes, it does. I mean, but none of these things are for the medical profession or the nursing professions to say, right, we're going to change now. This is across. What I was hoping to do with my book was to stimulate debate and discussion and thought around these things, and it's relatives, it's families, it's the dying themselves, everybody. I mean, as I said, may come as a shock, but we're all going to die. These are things going to affect us all. And when you see so little investment, I mean, if I remember rightly, the investment in palliative care from a research perspective is around about 1/100th of the investment financially in cancer therapies. And I remember from my time at NICE, some of the very expensive new therapies that came in would be a bit better, but only a bit better. And often the outcomes were still not terribly good. And yet we underinvest in things like continuity of care. There's good research evidence that if a patient and a doctor know each other, it reduces premature death, it reduces hospital admissions, it reduces overall costs in the health service. So why have we thrown all the money in the big technical exciting stuff and ignored something as profoundly important as continuity of that old sense of the patient and the doctor knowing each other, those phrases of my doctor.
Yeah, and I think, I mean, that's interesting because that relationship between patient and doctor was something that was very solid in society. But given the pressures now on GP practices, given the number of people seeking appointments, given the time limits that have been set on each appointment, do you think that has gone? Is that something we've lost, never to come back, or can that be regained?
Yes, it can. And I mean, part of the reason I called my book Side Effects was some of these things become the side effects, the unintended consequences of good intentions in the policy world. So for instance, the access to general practice in particular has always been a political hot potato. And if I remember rightly, around the time of the Blair government, there was a lot of concern that people could not see their doctor quickly enough. And so the Blair government brought in a 48-hour target to see your GP. So the aim would be that you would see your GP or a GP, this is the critical bit, within 48 hours. And money would be attached to that for practices to incentivize this. So practices very understandably worked out the best way to guarantee that the proportion of people that are seen within 48 hours is high, is to not allow anyone to book further ahead than 48 hours. Yeah. Your denominator and your numerator become the same. That's not cheating, it's just understandable human behavior. Yeah. As a result, patients phoning the practice would be told, yes, you can see so-and-so, but can I see my doctor? Know that your doctor's not available for 3-4 days or a week or whatever, so you can't have the appointment. So the government was trying to bring in a policy to improve access, but destroyed continuity. Yeah. So it was a side effect of a good intention, which has gone disastrously wrong. Is it rescuable? Absolutely. I was at a meeting last week, a lot of GPs passionate about recognizing the importance of this, but it requires workforce, of course. You just can't do it. You can't do it with the current workforce, which is desperately low.
Yeah, and of course, morale in the current workforce is bad. And I've just noticed a question has come in from somebody in the medical world talking about continuity of care. And his view is that that is lost in hospitals, in part because of the vast number of juniors needed, teams rather than named consultants providing care. There's the burden of IT locking down staff, apparently 68% of a junior's time, that the baton is repeatedly dropped. So how might that be solved?
Yeah, no, again, I agree with it, absolutely. Back in the dark and distant days when I was a junior hospital doctor, and I do not want to sound like an old bloke talking about his past. We worked in teams where my consultant, my registrars, myself knew each other, began to understand how each other worked. We were responsible for a group of patients. Now, with things like European Working Time Directives and all sorts of, again, well-intentioned policies, the team structure was lost. And so juniors don't feel quite as supported as they did. Senior doctors don't know who their juniors are. I remember when I've been in hospital myself for acute admissions, seeing about 3 or 4 people come round and not having a clue which one was my doctor. There might be a name on my bed, but I might not have seen them. And this stuff matters. As I said, the research evidence, particularly from a recent study in Norway, showed that if you had a long-term relationship or a known relationship with a doctor, it had far, far greater benefits than many of the very expensive drugs that we've prioritized over workforce.
Yeah, I mean, I think that's very, very interesting. And I do hope you're right that that can be regained. And I wanted to turn just briefly to one of the chapters in your book on the pharmaceutical industry. And what struck me about that was, I mean, some of the costs are eye-watering, really, in bringing a drug to market, etc. But what struck me in particular was the utter lack of transparency. Why is it costing so much? And how is this allowed to happen? Is there not some way in which regulation can be organized? Because they do surrender when they're pushed, as you've given some very good examples, trying to charge one price for a particular cancer drug, then they're told there's a cheaper competitor and they'll reduce their price. But it was astonishing to me.
I found the whole topic deeply depressing. I stress every time I've met people from the pharmaceutical industry or spoken at their conferences or whatever, I stress I am not one of these people who is appalled by the pharmaceutical industry. They have done wonderful things. They have developed drugs, that I said earlier, my brother died when he was young. Nowadays, he wouldn't have done because of what pharma has done. But how have we got an industry that if you Google, the pharmaceutical industry, you get thousands of pages of abuse of I mean, again, it fascinates me that so many people in the industry are deeply depressed about their image, their public image. And that comes down frequently to this pricing structure, which is nothing but greedy. I can't think of a better word. We get away with the price we can get away with. And maybe that's just business. Maybe I'm just being naive, but I find it deeply sad.
Right. And in many ways, irrevocable, because nobody seems to challenge this, despite the evidence that's there. And I wondered also, you mentioned earlier about fear of litigation, and there's no question society has become more litigious. And where do you think that has come from?
Well, it's not just in medicine, is it? It's
No.
it's across the board. So maybe you'd have to ask a lawyer in one of these sessions about that, where that's come from. The first reaction to tripping in a pothole is, who do I sue, rather than, so it's not just related to medicine. But the worrying bit about medicine is that if it then drives a behavior of over treatment, so the doctor is so worried that they'll be criticized for not having done scans or x-rays or whatever, that they do them unnecessarily, and then frequently discover things that don't matter but need to be dealt with.
Yeah.
So the more scans you do, for instance, the more doctors call them rather oddly incidental omas. You find things, little apparent masses or whatever in the body. If you hadn't scanned, you'd never know they were there. They don't matter, but once you've found them, you've got to do something about them. You've actually ended up doing more harm than good. And some of that behavior comes from fear of litigation.
Of course. And you're very interested in the book as well about how mental health has moved much more to the fore in a way that it probably should have long ago, but didn't. But can you see us reaching the stage where mental health and physical health are treated equally?
Well, they have to be. And the thing that, again, what is really interesting is how the barriers between those are actually, research is showing that they're probably nonsensical. We've had this mind-body, dualism for, centuries probably now, but it's but in fact, things like inflammation have a profound impact on physical as well as mental changes and disease. So I suspect they're nowhere near as separate as we have thought. And of course, I remember I was asked to speak to the Health Select Committee in the House of Commons around the time of, I think it was David Cameron was bringing in a thing called the Cancer Drugs Fund, which would prioritize the funding for new cancer drugs over other things. And as I pointed out to the committee, you're just as dead from suicide as you are from cancer. So why are you putting all the priority money into that aspect of care rather than the mental health side? No answer, of course, but and again, it almost comes back to this thing we were talking about earlier. Some things seem more glamorous and exciting, whereas mental health is critically important.
Of course, and has an impact on physical health, as your book so clearly demonstrates.
And as we're seeing at the moment, in terms of the, 500,000 people not returning to the workforce after I don't know how many of those will have long COVID. There's all sorts of possible reasons for this, but an awful lot of them have exhaustion, chronic fatigue, etc., and we're discovering how incredibly critical that is to our economy and to our society.
Of course, and just going back to the money for a second, the former Health Secretary Jeremy Hunt, now Chancellor of the Exchequer, last week announced a 3.3 billion lift for the NHS budget over the next 2 years. And the Chief Executive, Amanda Pritchard, says that this will allow the NHS to fulfill its priorities. That's on the one hand. On the other hand, Britain has spent an average of 40 billion a year less on health than similar European countries over the past decade. Now, do you think that infusion from last week really can address the priorities? Is that not just throwing money at something that really hasn't been thought through?
Well, I think it's certainly in the short term. My book is looking longer term than the immediate crisis. And I do believe that in the short term, we need money. And I think Amanda Pritchard's response was sensibly politically wise, let's put it that way. But one of the things that intrigues me is the way the amount we spend on health goes up and up and up. And there are extrapolations, and again, in every country, that if you extrapolate long enough, you hit 100% of GDP, and that's just, of course, not sustainable. So, one thing I write about in the book is, as a doctor, as a medical student, I was trained to look at the topic of anemia, where the body is short of iron. And to most people, you'd say, if the body is short of iron, what do? You prescribe iron. Now, the analogy here is the health service is short of money. What do? You give it money. Well, not necessarily, because in anemia, it might be that the iron is being given or taken, but not being absorbed, that the diet is wrong, that it's being lost, else, the blood is being lost whilst you're pouring this in. You can apply exactly the same sort of analysis to the NHS in the long term. So where is the waste, of which there is a lot of waste, particularly around areas of over-treatment, over-diagnosis? Where do we over-medicalize? We talked a few minutes ago, Gary, about the pharmaceutical industry. I was horrified to discover that a company has been researching a drug to treat the symptoms of loneliness.
Yeah.
And if anything exemplifies the nonsense of where we've got to in some of our talk on healthcare, it's that. Now, that isn't to say that loneliness isn't incredibly important. There's evidence that it's as damaging to health as smoking, for instance. But the treatment isn't a pill. The treatment is societal. And so I talk as well about practices, particularly one I'm very interested in Frome in Somerset, which has put an awful lot of effort into getting their practice population supported socially. And as a result, the health needs have plummeted. So that's a long answer to your question about money. What I'm saying is, it's not short term, we need money. Long term, we need to look what we're trying to do, and where is it not being used in the most appropriate and effective way.
Of course. And I mean, we have focused, of course, on the health sector, but thinking particularly of Sir Michael Marmot, whom you talk about in the book as well. He, of course, has spent a lifetime showing that if you invest in education and housing, et cetera, that improves the health issues across the land. And yet it doesn't seem to get traction. I know he has said recently that the issues he's been talking about for years keep coming back. And I'd fail to understand why we can't grasp this nettle.
Yeah, there was a lovely quote, I can't quite remember, Desmond Tutu, I think, in South Africa, talked about if you're by a raging river and people are floating past you, looking seriously injured or damaged or whatever, you can spend your entire time pulling them out, or it might be more sense to go upstream and see why they're falling in. And again, it's today's crisis, today's ambulance waits and so on are, of course, what we have to deal with. But in the long run, health depends on a good society where people don't feel isolated and lonely. It requires education. It requires good housing and so on.
Yeah.
It's not purely an NHS matter.
Yeah, so it's really a holistic approach that needs to be taken. But the Chancellor also said last week, if I'm remembering rightly, that his aim for the health service was Scandinavian quality with Singaporean efficiency. Now, I know we said earlier about failure to learn from international examples, but were you encouraged by that?
It was an interesting quote, because the Singaporean health service system is really quite complex, with multiple tiers of different levels of funding. I think what our population aspires to here is Scandinavian efficiency with American levels of taxation, and that's probably not doable. You have to somehow, we need to get that balance better. But as I've stressed, yes, we do need more funding in the health service, but that's short term. Long term, there are many other ways to address whatever it is that we want to achieve for our population. And I think that's to do with more people living to a happy, healthy, older age. I talk a lot about what's going on in Japan with the elderly, really interesting work on simple things like diet and exercise, which is paying phenomenal dividends, which we don't do. We just wait till a crisis comes and then spend expensively on putting it right.
And of course, technology has made a huge difference, often in very beneficial ways for the health sector. But we spoke earlier about that relationship between GP and patient. Now we have online consultations. There are downsides to this technology.
Oh, absolutely. But we had a really interesting experience at the beginning of the pandemic, if you remember, when first Secretary of State said all consultations should be online unless absolutely essential it's otherwise. And then the next Secretary of State said the exact opposite, that it must be face-to-face. The answer is that online can be really useful for some things. But frequently, face-to-face is extraordinarily important. I think we've all discovered. I've realised in my roles now, my non-clinical roles now, how much being in a room with someone changes the quality of the interaction. Whether it's a trust board or a consultancy or a charity or whatever, you just get a better quality of human interaction there. And I think, again, I remember in my many years as a GP, the incredible number of times I think I dealt with the problem. The patient would stand up, go to the door, and then say, "While I'm here, doctor," and then come up with the thing that actually had been worrying them, and they've been slightly too. And I don't think that happens in online consulting. I think it's too easy to click to the off. So I think there's if all you need is a certificate or a letter or something like that, then it's fantastic to be able to do it online. If you want to just stress your dis-ease with the doctor, then I think that needs to be face-to-face. So we'll find a way through that. Sure.
Yeah. And I mean, I speak to medical friends who tell me about the hemorrhaging of people from the service, junior doctors, consultants, nurses, people who are just burned out. Morale, it seems to me, is at a very low ebb. And I wonder, is there a danger we'll reach a point where actually this ship cannot be turned around?
It's a very depressing thought. And I think with no. I mean, we've got some ridiculous things going on at the moment. The thing around senior doctors' pensions, for instance, could be sorted out by the Treasury tomorrow. I mean, I'm no financier. I don't understand this stuff at all. But I think that sort of thing could very, very readily be dealt with. So it takes a long time to train a doctor, a long time to get them through to the consultant level. It takes one poor bit of criticism or poor bit of support for them to say, right, that's enough, and I'm off.
Yeah. And is there a danger, do you think, that we're losing the vocational aspect of going into the medical field?
No, absolutely not. I meet a lot of young doctors, and I am so impressed with their quality, their altruism, their passion around the sort of things I'm talking about humanity, about kindness, about caring, as well as technical competence. All these things really matter. No, I feel, assuming we can get through the current crisis we're in, and if we can keep morale up and retention of folks in the profession, the medical and the nursing profession, it's exactly the same as in medicine. And it's at a crisis point, as you absolutely say, Gary, but I think that is rescuable with addressing things like pensions, addressing things like car parking charges, just the silly things that drive people out of the profession.
Of course. Well, it is very important. We're coming to the end of our time, but that we do end on a positive note and not a depressing note. But so I wondered, look 10 years ahead. And one of our listeners has said, in the current circumstances, name the top 3 things you would change for the long term.
Gosh, that is such a good question. I'm not sure I can do that off the top of my head. I would, I deal with the urgent things of workforce, and that comes down primarily to retention and sorting out the admission to the clinical professions, nursing, allied health professionals, physiotherapy, medicine, and so on, getting the numbers through that we need, not relying on recruiting from overseas, which has a deeply worrying ethical aspect to it as well sometimes. So that's of critical importance. I would look at the importance of prevention. If we're talking on a 10-year time frame, that's probably long enough to begin to get some outcomes from that. I can't remember a single Secretary of State who hasn't talked about the importance of prevention, and almost every one of them has reduced the budget in public health or taken the money away from that bit. So supporting that, and I would try and balance out the investment between primary care and secondary care. We, over the last, there was a sort of a 10-15 year period recently when the number of hospital doctors went up by, I think, I can't remember the figures about, but it was about 50%. The number of GPs fell, and yet all the evidence was saying we need the exact opposite. And that comes back to what I've talked about the one bit being seeming to be glamorous, seeming to be noisy, seeming to driving the headlines, and the other bit that's just general practice. So I try and address that. I'm not sure if I've given you 3 there or if I've run out of time.
Those are very good suggestions. Very good suggestions, Sir David. Yours has been a hugely interesting contribution to this series of conversations, and thank you very much for that. And I would say to our listeners, do follow up your interest in this theme with this very, very interesting book. Thank you to all of you who have tuned in tonight, and thank you to those of you who sent us some questions, but most of all, thank you to Sir David Haslam for such a stimulating and interesting conversation. It only remains for me to say from St. George's House, keep well and good night.